Hey, good afternoon or good evening, folks. I'm your neuroscientist, Dr. Andrew Hill, and welcome to Neurofeedback and Chill. Tonight we're going to talk about Alzheimer's. So if you're watching, let me know how my audio is. I always seem to have technical challenges. I've been playing with audio. Oh, I have some echo somewhere. Let me go figure out which browser in the background is running and close that. Bear with me for 1 minute while I sort out my audio. There it is. I think that'll do it. I had another YouTube window open in the background for the live stream, and it started echoing what I was saying, which really confusing. I try to be clear when I speak, so just one of that is usually good. So hey folks, welcome to Monday night Neurofeedback and Chill. This topic is tying into Alzheimer's Awareness Month, but really the crux of tonight is this perspective. For most of my career, getting a real answer about Alzheimer's has been not so easy. You can get a spinal tap over the past several years, or before that, there was some evidence with amyloid identification with PET scanning, which is a radioactive tracer, and then an MRI-like magnet. But that was really distinguishing different types of dementias. It wasn't really perfectly diagnostic. Both of those things were expensive, a little bit invasive, required specialized facilities. So not really a screening tool and not really available everywhere. And you could do what most people ended up doing, which was wait, essentially. And for many years, the only way to truly get a diagnostic, firm category of Alzheimer's was after somebody died, and you did an autopsy and saw the changes in brain tissue. And with brain imaging, and again, things like PET scanning, positron emission tomography, you're able to get a little more sense now of different disease processes in aging. We understand more about dementias than we did 20 years ago, but it's still been a pretty technologically heavy process to evaluate and not something you can use as a screening tool. And so this, really meant that the definitive diagnoses happened after death, and it happened by pathologists, not by your primary care doctor, or even better, if you're an elder, by your geriatrician. If you're an elder, having a geriatrician is a great idea. If all you have is your regular primary you've had for 20 or 30 years who knows you really well, and you're 65, 70 in that neighborhood or above, maybe get a geriatrician and consult with them. General practice docs are great, but having a doctor who knows about aging deeply will help you understand aspects of typical versus atypical aging and navigate things, sometimes in a way that's different than primary care doctors who are not geriatricians. But this perspective has been for a long time that it's a little hard to diagnose Alzheimer's, and other dementias are a little bit hard to understand. And so there's different imaging trying to sieve them up one from the next. And then the progression, perspective for the past 10, 15, 20 years has been pretty poor. Still, as we understand more and more about the mechanism and the trajectory of change, we haven't had a lot of disease modifying treatments. We've had symptom modifying treatments to some extent, but nothing dramatic. Lots of promising things. The story, if you're not familiar with the sort of literature or the history of Alzheimer's research over the past 50 years, is there was always some sort of promising finding based on molecular mechanism or some mechanism that was theoried to be the cause of Alzheimer's dementia especially. And as those things moved from the petri dish out into the world, or the human testing, or even animal testing sometimes, there would be a certain amount of failure in the results. They wouldn't really translate that well. And I was teaching at UCLA courses on aging. I taught a year-long sequence, where the first couple of quarters, UCLA is a quarter program, so it was 3-quarter sequence. The first couple of quarters were more the biopsychology, biology, psychology, and sociology of aging. So that's really the model you teach aging under. Gerontology is a biopsychosocial study, if you will. All three are really a braid of phenomena that you can examine aging from. And so, a lot of historical perspective on aging and a lot of science in the first couple of quarters. In that third quarter, I did a brain aging brains. And it was a 10 or 12 week program, course. And a couple of weeks were on Alzheimer's and other dementias. And those were pretty depressing weeks in that, a lot of the perspective was we're starting to get some diagnostic signals in the literature, but we don't yet have a clear sense of the true mechanisms that are driving disease progression or the trajectory of decline. And we didn't have a lot of treatments to really, on the horizon at that point either. So all that started to change. I must have taught this course sequence for a good decade. And the last couple of years of that course, when I was teaching, I got to instead introduce some of the metabolic sort of biohacking work being done by scientists like Dr. Dale Bredesen, who since went on to create something called the RECODE program, which became a company called Apollo Health. And now they have a RECODE as well as a pre-code. And what those do is they look for the factors. Dr. Bredesen was this scientist, from what I understand, in a very similar boat to many Alzheimer's researchers, where he was doing molecular work and bench work and everything else, animal work, and not finding any translation up to the clinical picture, up to the patient level. And I think he came to UCLA. I think he was at UCLA when he did some of this work on a residency for a couple of years. Scientists do this. They visit from other universities. And he was doing some work on a metabolic set of interventions instead of all the drug interventions or the cutting edge small molecule interventions that were starting to be developed. He worked on a sort of lifestyle factor almost set of interventions, looked at the genetics, looked at the metabolic factors, inflammatory factors, blood sugar, etc., and came up with a list of about 37, 38 factors that drive, as far as he could tell, most of the signal in progression of dementias, and then developed a series of programs to help address those things. And they're very, very successful for some people. And the literature that I was presenting at the time, a couple of initial case study papers he published, each of which had, I think one was 11, one was 14 people or something like that. Amazing results, where people in their 60s and 70s and 80s who had 25, 30, 40% of the hippocampus left on both sides, living in memory units, locked facilities, not having the ability to function independently, would regrow hippocampal tissue and develop a perspective on recovery that was essentially close enough to typical aging that it was looking like people were recovering from mild to moderate dementias, especially the Alzheimer's flavor here. So Dr. Dale Bredesen's work's interesting. You can dig into it. I did not link it for this talk, but you can find it easily. And his company's Apollo Health, and it's one of the, at this point, there's been another decade since those studies were published. And other companies, other functional medicine doctors, other gerontologists, geriatricians, et cetera, now sort of know about this literature body, and many functional medicine doctors will use this. They'll look for your C-reactive protein and homocysteine and your different genetics for methylation and kind of help you dial it all in. So it's not only Apollo Health, but they're a decent snapshot of this approach. Now, backing up to the topic at hand a little bit, dementia. People often conflate these ideas, and if you haven't watched earlier live streams or podcasts I've done, if you're new, hi, welcome. Please subscribe to the channel. maybe like the video. I'm trying to get my subscriber numbers up to the place where they let me hang a plaque on the wall, and I'm really far away because it's a small channel. So why don't you subscribe and share it with your friends? End of plug for now. Dementia is different than Alzheimer's. Dementia is a symptom, and it shows up in different syndromes. Backing up one more level, a syndrome is a collection of symptoms without a really well understood cause or progression, etiology, essentially. And anything with the word syndrome in it ends up, at least initially, being categorized as something where we understand the phenomena of it a little bit, but we don't know why. Things like POTS, postural orthostatic tachycardic syndrome, or AIDS, the last letter there, syndrome. That's really a sense of, well, we can observe the phenomena as a stable phenomena. We know something about it, but we don't understand why. The mechanisms are not well understood. And so whenever you hear the word syndrome, you should, at least early on in the discussion of whatever that thing is, you should assume that you're thinking of a bucket of symptoms, and it's a bucket that it has captured symptoms, and there may be more than one thing in there. Autism is sort of an example of that. There's at least 2 or 3 different flavors of autism. ADHD. These are more syndromic in some ways. They're not called syndromes, but many things are. So whenever you hear that syndrome, remember that it means that at least initially we've had very poor clarity on the mechanism of things. I see some folks rolling in and saying hello. I'll stop and say hello to you guys. I see Radar Ashwood. Thank you for the audio check and the video check. I've been really playing with a couple of different items. I have a cloud lifter. I've got an Audient DAC. I know those 2 things are often used for the same purpose, but playing with them in levels seems to create an adequate audio signal. So let me know if it's clipping or too quiet, too loud, and I'll play with it and tune it for you guys in real time. I also see Ilya. Hey, Ilya, how's it going tonight? Nice to see you. A couple other folks are hanging out in the backgrounds. Feel free to say hi or ask questions. If you haven't been to one of these live streams before, the goal is to be informative and teach you stuff, things you can use, things you can understand, things you can teach other people, things you can share. And a lot of the goal is to, help you explore whatever it is you want to. So you don't have to stay on topic. If you have questions, just ask them. Hi, this is the Sonia, and I also see Brianna B. Hey, Brianna B 89. Audio sounds good. Thank you for the confirmation. Appreciate it. I'll stop and give myself a plug a little bit. So again, Andrew Hill, you're a PhD neuroscientist. I own a company called Peak Brain Institute with brain mapping and neurofeedback clinics in Los Angeles, New York City, St. Louis, West Palm Beach, Orange County, California, London, Stockholm, and remotely. We do full-time remote work round the calendar, round the clock, every day of the week. We're there at least 12 hours a day, depending on time zone, and we can do remote brain mapping, remote QEEGs, and remote guided neurofeedback. So if you need some help with us, get in touch with us, and I will help you understand your brain. If you're watching this podcast, this live stream, or any of my work, and you want to get a discount brain map, you can pay $250, $249, which is half price for a Peak Brain membership, and that will get you unlimited QEEGs at any of our offices. And I'll teach you to read them. You get at least 2 consults with me as part of that deal. While I'm in plug mode, I'll just bring up the books. So you guys have seen this thing. I've got this book out called Gifted and Tortured. A couple people are buying it every day, so thank you for buying it. I'm getting lots of great feedback. If you've purchased it, please leave me a review on Amazon. That really helps. There's a handful of reviews there, and I need to get some more. Another book is in pre-release. I actually have 2 more in pre-release, but I brought another image up for you. This one's all about meditation. This Half a Second More is a book that helps you understand sort of how time works in your brain, stimulus and response, perspective on attention, and also how meditation works a little bit, and helps you match different types of meditation to your brain, your quirky, wonderful, gifted, and tortured brain. So these are sort of companion books. I've kept the cover a little bit similar. I might redesign them to keep them a little bit more congruent and align better. But there's a 3rd book that'll be coming out in November, which is called Borrowed Peace. and that one's more about addiction and substance relationships. So we've got these 2 books out. There's some clinical books that my team is working on with me, a handful of them for practitioners in the field, one about neurofeedback, one about brain mapping, one about trauma in the brain, one about drugs in the brain, all a bit more deep and technical and clinically focused. And those are being released at the ISNR conference in middle of August in Vegas. So if you're interested in neurofeedback or brain mapping or biohacking of the brain, either as a professional or a consumer, come to Vegas. It's a few $100 for a ticket, a few days of the greats in the field. The field's very small, the field of neurofeedback. My estimations are that there's somewhere between a few thousand active practitioners and maybe 3-4 times that number who are less prolific, less visible. So not a huge number, maybe worldwide, there's probably about 10,000, I would guess, practicing at the moment. Maybe more, but something in that neighborhood. And there'll be a few hundred of them in Vegas for a few days. I'm giving one of the keynote speeches or keynote presentations on Saturday afternoon, I think, right after lunch. You can fill up on conference food and come be sleepy and hear me talk about some double-blind, placebo-controlled research on neurofeedback that I did, looking at how the brain reacts to the signal you're hearing. When you're watching a neurofeedback screen, if you're not familiar, you might measure 1 or 2 areas of your brain or many areas at once and do math to derive a signal that you're going to train. Either way, you're measuring some parameter or many parameters of the brain moment to moment that you want to train, quote unquote. And so you set a parameter, a threshold next to the parameter and say, okay, as long as the brain moves in a certain direction a little bit in this way, let the audio or the visual happen or keep happening, trigger it. And so the brain's sort of watching a stimulus. I often use simple animations or picture grids, Pac-Man eating dots. When the brain does something, let's say you're training beta up on the left precentral gyrus, there's a stabilizer there whose job it is to help you sort of put yourself in gear and keep yourself in gear and sustain your attention, your focus, your clarity, your sequenced action, even if things are boring and dull because you're doing the thing. Don't wander off into the bushes, So when that area is strong and making lots of beta, we lock in really well. And when the beta is not as strong, the tone of the beta is being replaced by more alphas and thetas and things, more automatic, more drifting, more disinhibited, then we don't stabilize the executive function that well, and we get inattentive style phenomena. We also get the same job of another job of the same region is to stabilize the depth of sleep by turning off all of those executive function aspects. So it sort of makes you, helps you stay awake when you're awake and on when you're on, but also asleep when you're asleep. So this left side precentral gyrus tends to get some difficulty with beta production, and that can affect sustaining how awake you are, but also sleep. And you might sit and focus on a screen or sit and be aware of a screen, and whenever the brain might flex itself a little bit in that direction with more beta waves, that's when it produces the audio and visual feedback, so to speak, that applauds the brain. And so I'm giving a talk on that Saturday talking about how we can see in a double-blind, placebo-controlled study sham versus real neurofeedback and frequency-specific responses of the brain to the process of training and durable change later on based on sham versus real. So frequency-specific, site-specific, and sham versus real effects all emerging really clearly in a fairly short course of neurofeedback, just 5 sessions in a row. And you're able to get effects that are significant. But by the very, very first session, if you're not coming to Vegas, here's the TLDR. By the very first 10 minutes of the very first session, most people, almost everyone who's getting real neurofeedback, their brain is echoing back the frequency that is being applauded. So if you made the beta come up on the left and applauded the brain with beeps whenever that happened, the brain starts to react by producing increased surges of beta, which looks like something, it changes the phase relationship of that part of the brain briefly as the amplitude goes up. And we get something called an ERSP, an event-related spectral perturbation. This variant is called an ERD, event-related desynchronization, because the beta waves happening are suddenly task-based, essentially, and not quite as synchronous. So they're reacting to the beeps, and the beeps are not yoked all that much. So lots of questions building up. Let me stop and answer them. But anyways, if you want to come to ISNR, that'd be great. Come hang out, say hi. We'll have a bunch of Peak Brain people there. If you've worked with the Peak Brain coaches, we'll have several of our staff, maybe 6 to 8 of us there. And it's a chance to come hang out and learn, but also meet some Peak Brain people. Guy Soleil, am I too late that I missed the video? Hello, Doc. No, Guy, I think you're here. I want to call you Guy Soleil. It should be French, right? Hello, bonjour, Guy Soleil. Unless you can't see it, you guys can still see me, right? Radar Ashwood is saying, do you think neurofeedback is dangerous for people with Alzheimer's? No, I don't. I think it's a little bit less effective once there's moderate to significant progression. I don't know of any good studies. I don't think there are any on Alzheimer's and neurofeedback. There are ones on speed of processing and neurofeedback, on brain brightening phenomena. There was a couple on driving, I believe, very small studies years ago, and they're all very promising. Once you're symptomatic with Alzheimer's, the neurofeedback, the typical passive training neurofeedback, is less likely, I think, to work as well. You probably need to move into 4-channel multivariate coherence training at that point, I would say. And I prefer that to something like 19-channel Z-score training. I think you're still doing only a couple channels, and it's not as controllable. But it's not as effective if you've lost a lot of tissue, and so you may want to include other things. I do HEG neurofeedback as well, not just EEG, but blood flow training. I think I have a device here on my desk that I'll dig out. It's basically an infrared camera measuring vasomotion. I have a whole video on vasomotion, but this is a little infrared camera you can wear, and you think happy thoughts or focus, and you drive up the blood flow, and the waves of heat start coming off your brain differently. And you can learn to exercise that through a process of biofeedback that's semi-voluntary. And dips in vasomotion, a flattening of the sort of fuel rushing out to the corners of the brain in response to distance and time, basically, or demand and time. The brain will float out different resources, basically, based on what it needs to, but also just in general. And that process of the resource resupply, waves of CSF, blood, et cetera, will get kind of weak under chronic stress, aging, inflammation, injury, et cetera. And so one of the aspects of aging that I would recommend training for many people would be the vasomotion, the hemoencephalography aspects. This is something called PIR-HEG, the sensor I used, which is passive infrared hemoencephalography. There's other variants of it, but I like this version. Also in dementias, especially if progressed, it's really hard sometimes to do interventions with people who already have significant dementia because I mentioned dementia is a symptom. It's a symptom of other diseases, and usually dementia comes along with confusion or anger or anxiety or fear. There's often some other uncomfortable emotion that comes along with it, especially in Alzheimer's. And if somebody is angry or afraid or suspicious, spending time to have them sit down and put wires on their head and set them up, it's a little complex. And if they've already lost tissue, it might not be worth fighting that fight initially. There are other things I'd recommend if someone's already progressed. And if you want me to do a full video on this, guys, let me know in the comments especially. And I will draft a video on sort of my biohacks for Alzheimer's. I was going to do something different next week and the week after, but I could squeeze it in perhaps. But just in general, I would examine cholinergic compounds like CDP choline, which can help support remyelination. I would examine, at this point, I would not recommend omega-3 fatty acids. There's some literature recently showing that omega-3 fatty acids will accelerate damage and change and disease progress if you already have it. Now, I think that might be because of the quality of omega-3s on the marketplace, but it's so risky to throw oxidized fats into your brain if you're already significantly impaired. So I would say you need to get food sources basically to be safe. But the real intervention that I would recommend maybe before EEG neurofeedback would be something like red light therapy, photobiomodulation. So maybe the red light helmets, also the infrared blood flow training camera I mentioned, the HEG system. Those are interesting. Bredesen's Recode protocol or a functional medicine screen like that, CDP choline, those are all potentially useful. And if you start doing metabolic interventions, metabolic biohacks, controlling blood sugar, getting enough protein in, raising endogenous ketones, and you start seeing something, then it's potentially worth doing more. And, you know, if your elder isn't somebody who's always eating all the time, which can happen, there's a carb craving thing that can happen in Alzheimer's, especially because neurons become insulin resistant, which creates carb cravings partially. Well, as long as there's a gap in food consumption, you can give your elder exogenous ketones or supplemental ketones, ketone esters, not salts, for the efficacy, especially in the afternoon. And if they perk up and clear up briefly, well, guess what? You have a metabolic pathway intact. And that's usually how it works because the neurons remain able to burn ketones for decades longer than they're able to burn glucose. Insulin resistance in neurons is a hallmark, we think, of especially Alzheimer's dementia. So tonight I was really talking about other aspects of dementia, but these are great questions, so I'll keep going. Hey, Jehan, nice to see you. What about near-infrared light and dementia, best frequency? Yeah, so for photobiomodulation, red light therapy helmets, I would use things that are up in the 1050 to 1070, 1080 to 90 nanometers. V-Light makes one that goes up there. Neuronic makes one. Somewhere I have a coupon from Neuronic, but I think it needs to be refreshed with their new products. So if you guys want one, I think I have an old coupon I can dust off for $100 off, and I'll reach out to them and get you guys a coupon if you want that. But yes, photobiomodulation I think is interesting. So is hemoencephalography, the infrared camera. So are some compounds like the cholinergics. There's a few other drugs that I'll talk about tonight as I get deeper into the topic I prepared for you. But great questions. Please keep asking them. Talking to you guys is the whole point. So I was mentioning how when I used to teach this stuff, it got a little depressing, and it started to change. And we started to see some of the mechanisms, and we started to see their behavioral and metabolic interventions that were making a difference for some people. That's exciting. And I do see some changes in these other biohacks that I mentioned. I would also avoid sauna, by the way, if you already have dementia. There's some evidence that can accelerate it. But cold, choline, high protein, high quality fats from diet, omega-3s from diet especially, those are all potentially very useful. And then exogenous ketones, because the brain retains the ability to burn ketones long after it's lost the ability to burn glucose. So this was the sort of story, the metabolic biohacking story, so much so that Dr. Bredesen built a company out of it that's very successful. But then in 2025, we got a little bit more of the story. We got a screening mechanism that was easy. The FDA approved a blood test to essentially detect Alzheimer's. Well, more accurately, to detect Alzheimer's-related amyloid pathology, a feature of how amyloid's changing that suggests Alzheimer's phenomena are present. And this is a blood draw, not a spinal tap, no radioactivity like in the PET, no climbing into a scanner that's full of helium and costs $1,000 an hour for the facility to run. That's why MRIs are expensive and PETs are expensive, by the way. Those things are full of helium, and we're basically out of it, right? Globally, just about. Stuff's rare, and you can't store helium. It's too small. There's nothing to store it in. Anything you store it in, it eventually leaves and goes to space. It's too light. It's out of here. So we have a blood test now. I'll explain what it's doing, but the question becomes, once there's a sudden, once there's an accessible tool like this, is, well, should I get tested? And I think the answer here depends on what question you're trying to answer, because the test is answering one question, but people actually care about something different, I find, usually. So I'll tease you a little bit YouTube style, and we'll get into the topic here. So this the test is called, it's something only a laboratory scientist could love, Lumipulse G p-tau 217 to beta-amyloid 1-42 plasma ratio. That's the name of the test. The biology is actually pretty similar. It actually is spoken out there by the ratio. It's two major protein pathologies that we want to talk about in Alzheimer's is amyloid beta, and there's tau. Now, amyloid itself is not abnormal. Amyloid is part of the innate immune system. It's not the educated immune system the same way that like T cells are, but we're born with another immune system that is there to get after stuff that is really deep and necessary, the innate immune system. And the amyloid appears to be at least partially part of that. And there's something called APP, amyloid precursor protein, which is something becomes amyloid and it's cleaved, it's separated into amyloid, and it has several different cleaving sites, and the amyloid it can become is variable. And so amyloid's really complex, you know. There's some societies, some ethnicities that are super high in some of the things that cause amyloid to oxidize faster, like APOE4 or 2 copies of it. And in some cultures, like in Papua New Guinea, where everyone's APOE4/4, and they eat hugely starch-rich diets, tubers, etc., they don't have any Alzheimer's, because the amyloid seems to be acting like a microbial immune system, and it's actively engaged, and therefore the brains are kept healthier. There's also other factors. The primary one probably being caloric excess is not constant the way it is in countries where Alzheimer's is so high. It's definitely a diabetic component to Alzheimer's, we believe. But amyloid itself has these different functional, subunits almost. And when amyloid becomes dysregulated, it starts to accumulate, get sticky, and forms these plaques we associate with Alzheimer's. And aside from amyloid, we have another protein called tau. Tau is involved with making up the structural filaments, the microtubules inside of neurons. In Alzheimer's, tau becomes chemically altered and starts to form tangles inside and even outside the cell. So plaques are outside the neurons, tangles are more inside the neurons, and the tangles are kind of interesting. It's really outside the scope of tonight's topic, but there's some evidence, this is going to sound a little out there, but there's some evidence that tau may be how consciousness is sort of assembled in real time. Tau is made up of microtubules are made up of tubulin, little rings basically, and the rings stack in this perfect way, and the rings are full of tubulins full of tryptophan, and the tryptophan molecule in the tubulin all lines up perfectly down the microtubule in a certain pattern, and biological energy will hit this channel, this microtubule, as it runs down the neuron and in other cells, and the information hits one section of the tunnel basically, and we don't know how this works, but there's been experimental evidence recently validating the idea that the microtubule has the ability to do quantum state management stuff, and it's able to hold information. There's two ways. This is, again, is off topic for tonight. If you want an actual whole hour on this, let me know. The quantum consciousness theory, basically, the OOR, Objective Orchestrated Reduction of Consciousness, Roger Penrose and Stuart Hameroff, the idea that the collapse of the quantum wave function in the microtubule seems to be involved with consciousness somehow. And the experimental research is showing that there's two states of those microtubules that are really unusual. One is, what's it called? I'm not a physicist. Microradiance, superradiance, I think. And essentially, when metabolic energy hits these molecules of tryptophan on the tubulin, they almost fluoresce. They sort of glow with biophotons, which are too small to see. People always talk about the brain emitting light. It does not emit light that you can see. And it's often infrared, or ultraviolet. So these little energy exchanges are happening, and this happens from the mitochondria throwing off energy, but also reactive oxygen species act an awful lot like an energy input to this same system. So what you have is energy landing in the input. All the microtubules from the neuron end up in this collection area where the energy is sort of being dumped in, and the energy as it comes in can hit the microtubule and cause this radiance phenomena, super radiance, where all the little tryptophan molecules, instead of each one lighting up like a little light bulb, they all light up at once, but in a way that is stronger than they should be able to individually. And light zips down the tube with a brightness and an acceleration that shouldn't be possible. And the idea here is that it's probably doing something in terms of quantum tunneling, it looks like. This very strange phenomena. And for years, physicists have scoffed and said the brain is too hot, too wet, too noisy to sustain a quantum state. But the superradiance is an interesting phenomena. It's been experimentally demonstrated. The other thing that's really sort of interesting is as a secondary state, the microtubules seem to be able to, so the superradiance is a bright state. It's too bright. It's like an informational boost of a signal somehow. The other state is a dark state where the metabolic light, if you will, metabolic energy comes in, and the phase angle, I'm not sure, I don't fully understand that, but I can dig in if you want to know about it. The tubulin, the tau, the tryptophans, the tube basically changes briefly, and it traps the information in the microtubule. And it traps it for tens of milliseconds, which in quantum world is forever. So this is the idea about how consciousness is both instantiated and persisted. It's not exactly like a transistor, but we seem to have the ability to crystallize energy as well as to give a 1 versus 0 state out of our neurons. And there's a lot more there, but OR, orchestrated objective reduction, is the theory here if you want to get into it. VJ, hey VJ, nice to see you. VJ is sharing, yo, got a sneak peek into Half a Second More. It's a brilliant book. They keep getting better. Oh, thanks, man. Demo Vicious, hey Demo. Demo had a neurofeedback not dangerous for anyone. Neurofeedback is not dangerous for anyone unless you keep doing it, it feels wrong, and you push the brain progressively in the wrong direction. You can create side effects, and most flavors of neurofeedback can do that. Some flavors of neurofeedback do it a lot faster. You have to be very careful with neuromodulation technologies, for instance. But most flavors of neurofeedback are really gentle and create a subtle after effect that you can then reinforce more or let wear off. So you have some control over it, yeah. But I lost you at phase angle, Damo. Okay, all right. Basically, there's this phenomena inside the microtubule of superradiance or dark states. And it's something about the internal conformation of the microtubule. Also, the microtubules are involved with the phase angle, again, of gamma and theta. So gamma about 40 hertz, theta about 4 hertz are resonant. They nest, right? You get 10 gammas for every 1 theta. And they basically stay coupled. That's the phase angle there, D. And when you distort the phase angle, when you change the timing relationship of thetas and gammas, the unconsciousness happens, loss of consciousness happens. And this is how anesthetics work for surgery, for instance. Well, some of the theories about Alzheimer's and about aging and memory are starting to suggest that changes in the tryptophan inside the tau may be partially related for some of the direct memory complaints in dementia. That's the very long-winded side quest on quantum consciousness that we just went into. But if you want an actual quest, let me know. VJ sharing, neurofeedback teaches you so much about self-awareness. You mean like probing your brain and noticing after effects? Yeah, it does. It also gives you more ability for self-awareness because it stabilizes your executive function. It stabilizes your sleep. It's a whole lot easier to be self-aware if you're not being reactive or, you're super tired, super grumpy, super irritable, anxious. So, yeah. So this blood test is a ratio of phenomena that are showing up in Alzheimer's, basically. plaques and tangles. These are protein signals in the downstream, in the body bloodstream, that seem to track pretty strongly with the neurological changes we see in the brain and the imaging identification of the such. One of those signals is called P-tau 217, and this is a modified form of tau that shows up in the bloodstream, and it rises as Alzheimer's amyloid develops. The other is amyloid 142, which tends to fall in the bloodstream as amyloid accumulates into plaques in the brain and starts getting sticky. So the ratio between these two in the body bloodstream is what you can use. One goes up, one goes down, and that ratio, the signal is sort of amplified because they're moving in opposite directions. That's really why it's so elegant, I think. The real breakthrough here is not so much the identification of these proteins, it's the measurement, because we've known this for a while, but these exist in the body in extraordinarily low concentrations. And being able to get a signal that you can measure the variance of to know what's important, that's really, really hard to do with little tiny signals. So for years, we simply could not measure these signals accurately, the amount of these proteins. But the modern assays, the ultrasensitive ones looking at fractional components in our blood, these can do it. So we're not, Theranos land. These are true blood tests. A single blood draw can basically provide the same information that's used to need a spinal tap for, or a PET scan for, maybe both. And the tests in the recent set of studies performed really, really well. VJ is sharing. It does teach you so much about self-awareness because monitoring well, being critical for alert training. Oh yeah. Also, for asking you every day, how's your sleep? How's your day? I mean, D, you always joke, how's your sleep is the first thing you say to me because of the emails you get every single day. But how is your sleep is important because it tells you so much about how your brain's working. And if I get you to reflect on your sleep, your stress, your attention, your other goals day to day, I mean, what is measured is managed per Drucker, right? So there's something here with biohacking and wellness. So anyways, back to these tests. The ones the FDA reviewed showed high agreement with the imaging studies. And again, back up for a second. This is not a test of do I have Alzheimer's or will I get dementia or even how healthy is my brain. This is a question of, is there evidence of Alzheimer's type pathology accumulating in my bloodstream? So this test was designed to answer that question, not a greater or lesser question. And what that means is if you're already symptomatic and you do this test, it'll help you understand what's happening. But if you're young, you'll see a level. I mean, we have amyloid from the innate immune system. You'll see some level. And we don't yet know, because all the research was done on elders that were symptomatic, what that would mean. So this is kind of like going and getting some test, that really has no bearing for you, like a prostate exam for a 16-year-old boy, I mean, your level might be useful to know so you can watch it change over 40 or 50 years, but it's just not likely to be a thing for that kind of population. And that's sort of like this. You'll have some amyloid in your system, in your bloodstream, but is it important? Probably not, unless you're trying to assess to what degree the memory difficulties you're noticing could have a dementia, really an Alzheimer's flavored dementia phenomenon happening here. So the FDA cleared this test not for identification of Alzheimer's, but for people who are already experiencing cognitive symptoms and are being evaluated by a physician. Now, again, this is exactly the same thing that happened with the imaging studies. The PET versus SPECT versus fMRI studies that were out 20 years ago, those were not diagnostic for Alzheimer's, but they could sort you into Alzheimer's, frontotemporal dementia, etc. And it wasn't necessarily even for treatment. I mean, a little bit. Some of the dementias work in counter metabolic pathways. So if you treat the wrong one, you could be accelerating things. But most of the reason we were distinguishing, frontotemporal dementia from Alzheimer's was for insurance purposes. So the insurance knew how to prepare for coverage or not. And it wasn't really so we could then match the best treatments. But again, just like we've gotten a lot more information about the etiology of Alzheimer's in the past decade, we've also started to get treatment. So now we have this new test, which is able to screen people who have thinking difficulties, people with mild cognitive impairment, with early Alzheimer's. This is a great population to screen for because we're starting to have trajectory. So, you might want this test if your mother or father had Alzheimer's, or, you have some memory, some short-term memory. But a couple things. One, unless you're 55, 60 years old or above, it's probably not worth doing because it's going to measure amyloid and not necessarily a progressive ratio. Two, if you're getting Alzheimer's type features in your 50s, then you know it because you have the presenilin gene in your family. Again, most flavors of Alzheimer's and other dementias are metabolic and take a long time, 30 years sometimes, to progress into being. So you don't get it in your 50s, you get it in your 60s, 70s, 80s, really 70s and 80s are prime. So I'm not sure I'd bother screening that. I'd more recommend folks that are concerned, who are pre-symptomatic, asymptomatic, young, etc., to go get things like the RECODE or other functional medicine screening. Now, another piece, though, I want to stop and talk about, because people all the time, when I work with them, are concerned about their memory. A lot of time, people in their 40s, 50s, and 60s are terrified about age-related cognitive decline and noticing things like short-term memory issues, tip of the tongue, hunting for names, little delayed recall, things that show up later but not easily, sticky, sluggish, delayed recall. And they're terrified that's a memory phenomenon. And guess what? It's not really memory. That exact phenomena of word finding, of tip of the tongue, is a timing phenomena largely. The left hemisphere has to time between the receptive and productive language areas to produce and monitor language as you make it. And there's a retrieval phenomena to insert itself into that loop. And especially if you're not sleeping well at night, the resting idle of all the circuits in that hemisphere will start to slide past each other, and synchronizing them as you start to think or use the system is actually a little tricky. And this is why you notice it with like word finding and names and things, because you're synchronizing across big tissues and you notice the timing lag there, basically. So this test is not for you if you're 55 and can't remember where the keys were, or you're forgetting your childhood friend's name. Probably not. Those, now we're in the land of quantitative EEG, functional analysis. Now you come into one of our clinics, put a cap on your head, squirt it full of gel, sit still for 20 minutes, also do the world's most boring 20-minute attention test, and I can show you how you perform against people your age. And then you'll see if the alpha waves are slowing down and the delta waves are swelling, which is a fatigue, a brain fog phenomena. Or maybe you'll see that you have low beta on the left-hand side, which means you're not staying awake enough when you're awake or asleep enough when you're asleep. So there's a sleep maintenance complaint that seems to be visible, or a handful of other things. So this is what I primarily do, is sort of helping people understand their brains and then pursue structured interventions for making change across a few months. So if you're struggling, book a free call. I think I have it in the show notes, the link for that. You can also come to peakbraininstitute.com website. If you don't need a brain map, learn about your brain anyways. You don't have to come get an expensive brain map or do expensive neurofeedback with us. You can buy a book. They're pretty cheap. Both of these books are up for $10 on Amazon as ebooks, and I think they're 30 as paperbacks. I've turned off the author pre-sales on Gifted, and we're now doing author pre-sales on Half a Second More. So Amazon will have Half a Second More on June 30th, and I will have pre-sale copies in my hand a couple weeks later, and I'll sign those and send those out in July. And I'm only going to do, I think, 50, maybe 100. I think I put 100 on the counter, but it's a lot to track and chase, and I don't want when people wait, weeks for books. So important to get those if you want a signed book. Grab a copy of Half a Second More. You can go to peakbrainpress.com and you can see all the books there. Both Gifted and Tortured and Half a Second More have a quiz. So if you want to see what kind of meditation you might want to do, go to halfasecondmore.com. That might actually work. Let's see. halfasecondmore.com is the book website directly, or giftedandtortured.com is the other book. And they both have a quiz. Gifted and Tortured helps you understand the brain phenotypes that make you quirky and awesome, but also a little tortured. And Half a Second More has a practice matcher, helps you understand which of those phenotypes might be the most in the way or benefit the most from different meditation practices. And they try to match a style of meditation for you and give you some perspective on what you can do there. So you don't even have to buy anything. Just go and take the quizzes and you'll get some actionable ideas out of both books. VJ sharing, the books teach you a lot. Thanks, VJ. Yeah, I think so, but I'm a little biased. So, but yeah, I'm also working on a resource that I'll release in a week or two, which contains every bit of research that I could assemble on neurofeedback, every paper I've written, every book I've written, both published and in pre-publication, as a giant knowledge base that you can extract information from and surf through and chat with. I think that'll be out and available in a couple of weeks, and I'll share that with you in a minute. But for now, you can take these quizzes. I'm enjoying creating little assets that take some of the concepts in the book and help you run with them. And those quizzes are part of that. So, no need to spend anything. Just buy a quiz or just fill out a quiz and give me your email. And then you can unsubscribe when I send the confirmation. I won't spam you. I'm not super high volume. I usually send an email every few weeks. If you want one, grab one. If you want me to sign one in person, come to ISNR in August. So let me grab my notes again. I lost them. All right, here we go. So, the changes in amyloid and tau, we now have a way to tell these ratios and have you understand what's happening in your bloodstream. So I think this can be a big part of other signals, other diagnostic information in your tool set. Just like you might do the Apollo Health Recode program or Precode program if you're young, you might do a regular lipid panel, colonoscopy, all these things you should do to sort of maintain the machine. This might become one of them to look at these features. Also, it's worth mentioning there's a few other things that can throw off this ratio. It's just like, if you're a bodybuilder or you're a CrossFit person and you go and get a blood test with your doctor and don't tell them you're a CrossFit person, they call you kind of terrified because your liver enzymes are elevated and you have broken down muscle tissues, and it's because you've been working out too hard, basically. In this case, something similar happens. Kidney function, the GFR, the glomerular filtration rate, the nephrons in the kidneys, can be impacted, and it can affect this ratio significantly. So just the kidneys themselves can skew the signal. So again, this is important detail, but it probably belongs in the context of a broader clinical evaluation and getting some good health coaching or medical perspective. So we do have tools like the Brazetin Recode and other functional medicine approaches, but you can also use things like neurofeedback. If you're not progressed, then I think the tools can really help. I also, think that for certain types of dementias, there may be certain tools that can be really useful. Like frontotemporal dementia is a vascular phenomenon. There's also vascular dementia, which is vascular, more than the medial temporal lobe tissue loss, which is Alzheimer's, the hippocampus, etc. The parahippocampal tissue first, I believe. But if you have vascular dementias, then that infrared blood flow training tool I mentioned might be useful. Or maybe the photobiomodulation red light therapy might be more useful, versus Alzheimer's, you might want to lean more into the type 3 diabetes, exogenous ketones, eating like an 80s bodybuilder. If your elder loves, eating steak and eggs, guess what? Steak and eggs. But it's hard to make behavioral change if somebody's already having significant symptoms and they're suspicious and angry and confused. So, you have to sort of try different interventions. And this is why red light therapy can often be useful, because it's a lot easier to be like, all right, let's watch your soaps and let's wear a hat that'll stream some light onto your head with very little setup and no goop. So that's a pretty big win for some people. Also, in the clients that I've worked with, as well as in the companies that I've worked with that use red light therapy with their client bases, there's something there. Photobiomodulation sometimes can make a big difference. Not night and day. And again, I think this is more moderate, not severe, where we're seeing change. But there seems to be something in the red light therapy landscape. And again, we're still learning to understand that. I did a biohacking with photobiomodulation or biohacking with red light therapy talk last year, so go grab that video if you want. So anyways, maybe if you're an elder dealing with cognitive issues, then check your amyloid ratios, because you can't feel them, kind of like your blood pressure. You can't usually feel it until the point it's problematic. So this is the topic tonight. I think I've largely covered the topic. Again, my bias is snuck in that the brain is a trainable system overall. And if you're young and not experiencing memory phenomena, then you have other things to worry about to some extent than amyloid. But you can still work on brain healthy phenomena to steer you away from these trajectories. You know, and there are 2 or 3 drugs. I'm not going to pronounce their names tonight, but there are 2 or 3 drugs now that seem to be changing those amyloid and tau progressions. And so that is the sort of takeaway here, is that once the screening becomes simple, you know, you do a blood test when you're 50 and look for C-reactive protein or something. You know, you also will look for this ratio. And if the doctor goes, oh, your ratio is kind of high, it's a lot higher than last year, then they might put you on drugs to reduce your amyloid burden, which we don't yet have a clear correlation of reducing amyloid and reducing symptoms. We've had several drugs historically that in animal models, and even one in human models, that lifted amyloid plaque burden, but neither of those paths produced better memory function. So this is why I think it's more complex, and maybe that microtubule story and the construction of the tau by changes in molecular structure regarding the tryptophan, maybe that's really where the action's going to lie. But we're getting closer and closer. We do have treatment-based disease-modifying, a little bit, trajectory-modifying treatments now, which is very exciting. So it's just going to keep getting better and better. And I've given you a handful of things to pursue if this is of concern to you. But either way, you know, ask questions. Come back and watch the video again if you want. Ask for more topics. If you something you heard about that I didn't follow through on a promise in this video, my side quest left you wanting more, just say the word and I'll expand those topics or direct you to things you can watch or read otherwise. So guys, it's about 7 p.m. Pacific time, coming up on our hour. If you have other questions, get them in. I think next week we're going to talk about a vaccine. It's been around for a long time, and it seems to really, really reduce your risk of dementias. So on that note, I will let you go. You guys take good care of your brains. I'll see you next week.